Hi, everyone, and welcome back to UCLA Health's Medically Speaking. I'm Dr. Eve Glazer. Advocacy is one of those words we hear a lot, especially in conversations about healthcare. I think we know that it's all important, but sometimes it's hard to imagine what it actually means for us as individuals, as patients, as families, or even professionals trying to figure out how to make a difference. Today, I am joined by a woman who is quite literally a living example of what it means to be an advocate on every level. Her work has impacted government policymakers, clinicians on the ground in low to middle income countries, many individuals, and their families living with breast cancer, and most of all, her own experience with breast cancer. It is with the utmost pleasure that I welcome Dr. Felicia Knaul to the podcast. Dr. Knaul serves as the Associate of the Chancellor at UCLA. She's a senior advisor to the Dean and President of UCLA Health. She's an economist and a global health researcher. And among her many accomplishments, she's written a deeply personal and very beautiful book, Beauty Without the Breast, sharing her own journey with breast cancer. Felicia, thank you so much for joining us today.
Thank you for having me and for doing this podcast, reaching out to so many people.
It's just incredible that you're here. I'd love to start today's episode talking about you and your background. And maybe we could start with your personal journey with breast cancer.
Of course. And thank you. So this year, a very auspicious year, my 18th year since my diagnosis, which was in October of 2007. And with no family history, no reason to suspect or worry about it in my first baseline mammogram at age 41 in a small clinic in Cuernavaca in Morelos in Mexico, I was diagnosed with an invasive breast cancer. Stage 2, let's call it. Luckily triple positive, so there was so much to be done with that cancer, which is a message that, women need to understand that now, today, some of the most aggressive form of breast cancer are some of the most treatable, in great part because of a discovery at UCLA Health of trastuzumab, of Herceptin. So I was diagnosed with this very invasive breast cancer, this very aggressive breast cancer. Again, age 41. My children were 11 and 3. Wow. And with no reason to suspect. And it turns out that I do not have BRCA, even though Ashkenazi Jewish heritage is mine. So we went into this kind of blind. I had never worked on that topic before. It was not my issue. I'd worked quite a bit on issues of children with cancer and access to education, but this was all new. And we can talk a little bit about how that, story unfolded, but I was very lucky to have amazing treatment in Mexico, and then an incredible orchestra leader, Dr. Julie Graylow, who is at the Seattle Cancer Care Alliance, who allowed me to really get the best possible plan for my treatment in place, and here I am.
It's interesting as you, and thank goodness you're here. We're so grateful for so many reasons. You mentioned that you were 41. This was a screening mammogram.
Yes.
So, just to break down everything for our listeners, screening meaning that you had this test done in the absence of symptoms, correct? So you weren't having any, quote, symptoms, changes in the nipples, nipple discharge, dimpling of the breasts, pain, lumps, etc. And I really want to emphasize that, right? So you went for your routine screening mammogram, but it must have been all the more surprising then. Like you were saying, you didn't have any, quote, known risk factors. But then to get this diagnosis, can you tell us about maybe how that felt?
Of course. And, there's a part also in the book where I think back and I think, maybe there was something. Was there discharge? Was there something I didn't pick up that I should? I think every woman, we attack ourselves. Men, too, when are diagnosed with this disease, which does happen. And I have to say, usually this is what I say to the women that I work with, many of whom have no risk factors and do not have breast cancer. When I'm giving talks, I say, look, your job is not to find out if you have breast cancer. It's to look for changes. And especially for younger women, especially where there isn't access to mammography, many of the places I work in, if you know that you're clear at a certain point in time, month to month, look for a change.
That's right.
And then go and have a physician check, is that change significant or not? That is your job, to look for changes. So I didn't believe it. I assumed I was, there in this clinic in where we have our house in Cuernavaca. And I figured that they were keeping me there because I was married to the former Minister of Health, my husband, Julio Frank, who had just finished up as Minister of Health of Mexico. And they kept saying, no, we have to do more pictures. And I said, I got to get to a meeting. I've got someone waiting for me. And I called my OBGYN, who is a good friend of mine, Dilys Walker, who actually works at UC now. And I said, like, Dilys, they've got me here because of who I'm married to. She said, okay, put them on the phone. And Dilys then said, you need to stay as long as they need you to stay, which is my first sort of inkling that something was, very wrong. And then I started asking questions, but they couldn't answer them. And it was, pretty clear I had a bad BI-RADS score, which is what, you score on a mammogram. And that was what it was coming into. And then it was clear that there was something that could be felt. I went over to her office that afternoon, felt something. We called Julio. He was en route back from Europe. He didn't believe me. He said I was exaggerating at first. Yes, it was he's like, you got to be exaggerating. It can't be that bad. And Dilys got on the phone and said, it's worse than what she's saying. So come back. And that was the first while. But the first... do
you think that was part of his shock, kind of, the exaggerating comment?
I think that because there was no reason to believe that this could happen. And, the first reaction of anyone who loves you is, of course, you don't have cancer.
Right, of course. Yeah, that's what I mean. Right? Exactly.
It's just... You've got a screening mammogram, you're 41, you're worried, but you don't have to be this worried.
It's such an important point, though. Yeah. I think people think that there has to be a reason, right, to get cancer, that you needed some exposure or that there's some genetic risk. Yes, those do exist sometimes, but often there isn't a, quote, reason.
Especially with breast cancer.
And another reason why, to get your screening mammogram.
Your screening mammogram, and if we can go into it for a minute,
please.
I really think it's extremely important to know your body.
Yes.
And know your breasts.
And how they change.
And how they change. And your entire body, to feel comfortable touching and exploring yourself in all parts of your body. And this is what we can teach, very young women. This is what we need to be teaching when we're in junior high, high school, and even earlier. Feel comfortable touching and knowing yourself. Feel that you have a beautiful body and you want to get to know it. I think that's really part of what we have to do as individuals, as women for sure, but anyone. And then you observe changes over time, right? Because we know that mammography is not especially effective on dense breasts, and particularly below age 40. And by the way, no magic number on 40. Like, it could be 42, it could be 43. We talk about 40, talk about 50, but we don't know the exact age at which mammography should start. What we do know, as you know very well, is that it's not especially effective in younger women. So what do we offer younger women? And in the places where I work, I talk a lot about breast clinical exams. And I speak a lot, and I believe in this very strongly. We have research to support this. You do not need a physician to do a breast clinical exam. A health promoter can do a very effective breast clinical exam. You need to actually have touched and felt a lot of breasts and some cancers. And so a health promoter who has good contact with the community, a nurse, someone working in a hair salon, seriously, is a very good potential advocate and person who can help a woman to undertake breast clinical exam. Because we're not trained for that. As individuals, we're not trained for this. But we can train.
Right.
We can train on how to do exploration.
Well, and I love what you said, too. I mean, the first step is just training on yourself, which is to say, just know your own body. Exactly. And know something feels different if it changes, but also get to know your body. And, I mean, appreciate it, but also it's yours.
And map it. That's what we actually do.
Absolutely.
You have, 2 circles, and you have a 3 o'clock and a 6 o'clock and a 9 o'clock
best.
on the right or left. And you mark what you have. Because you can have a perfectly benign lump in one side. It's been reviewed, and you know it's there. You've got it marked, and you look for changes. But the others, in the places that I work, it's the inverse of here. The vast majority of women are diagnosed in stage 3 or 4 when we're speaking about lumps the size of oranges or worse. And there is no question that with an exam using your fingers, you can downstage that. And so we're trying to push towards downstaging. I'm not saying with breast clinical exams, you can manage to find that, 1 centimeter or that stage 1, but you can do better than stage 3 or 4. We see just masses that never should have gotten to that level.
Right.
Right? And that's what we're trying to do in a lot of the places. But I think it's also just a very relevant message, given that we know that breast cancer is increasing among younger women, and we don't exactly know why. So what do we do about it if mammography is not ideal? We look at ultrasound and we look at, actually being able to explore with our hands.
Right. I mean, you and I were talking before we started today, but we both have daughters. What message should we send to the younger generation, I think?
I think it depends on whether or not there's a history in the family.
Sure. Right. And where they live.
Yeah. So, we know, and we have to be clear about it, that we suggest that the daughters of women who have had breast cancer think about having MRI, mammography, or ultrasound 10 years before age of diagnosis of their mother or father. Not because we're sure that mammography is the best, but when you complement it with something else, it can be extremely effective because we know risk is higher.
Yes.
Right? I think the decision to, and we should talk about this a little bit, is what is a previver? When do women decide, and when is it the right decision to have a so-called prophylactic mastectomy? I think this is something that many of our daughters ask themselves.
Yes.
What is the right time? Should we do this? Should we not do this? What are the other options? It's very different when you're living in a country where you really don't have access to care. Yeah. And where you can think about reconstruction, where you don't have the same choices. But, overall, the message to daughters of women with breast cancer is start earlier, and you need to be followed up much more closely. But I do think we need to talk really seriously about choices around mastectomy and why and when, having done it.
Right. Well, and it's I actually hadn't heard that term, previver. Can you tell me a little bit about that?
Previvers are, women who are at risk, but they do not have cancer, and they choose to have typically a double mastectomy. Right? They may or may not have the gene, and then you can combine it with other things like oophorectomy. And, I think every decision is a personal one and can be justified. I personally waited 15 years before I had the other breast off. And I think, there were many reasons why I finally decided to do it. So I just think it's a very personal decision.
Yes.
And it's not an easy surgery to have. I never refer to this as top surgery, with all due respect to those who use that word. It's a very serious surgery. It doesn't always work out as well as you'd like it to. And you don't do it because you think you're going to look better afterwards. This is sort of, I think, one of the most important messages. It isn't a cosmetic procedure. Right? And I think that there's a little bit of risk here that women would run into it thinking, and I've been told that myself. You'll look better afterwards.
Right.
Right. You have all sorts of options to be much perkier. Let's put it that way. That's not the reason to do it.
Right.
And it doesn't always work out that way.
No, and it certainly comes with risks.
Comes with risks, and there are all sorts of options that do not involve a mastectomy, which is an amputation in the end. And making sure that women have access to those options, I think, is hugely important.
Yeah. I mean, it sounds like, thankfully, that, you were able to have a wonderful care team. You mentioned your GYN, I think, when you were in Mexico. Can you share how you chose a treatment path and how you assembled, your own care team?
Of course. So, that's an interesting story because sort of stage 1, which is like the first 100 pages of the book, is me, not accepting that I actually have a cancer diagnosis and going through the different processes of the biopsy, et cetera, and how that played out. And lots of time being incredibly frightened and depressed. And then getting the diagnosis and deciding that, I really wanted to save my breast, and going through multiple surgeries, even though my surgeons were saying, look, we can't get clean margins. The right decision is a mastectomy. One piece that was really important there, really, really important there for me, is that they didn't expect that I would need a mastectomy when they first went in. So they hadn't talked to me about it. And thank goodness they and Julio decided to wake me up and talk to me about it, because we know that one of the most important and decisive factors in the success of a mastectomy is that the woman has to be choosing it. It's got to be your decision. And I had not made that decision. So, I struggled surgery after surgery to try to get clean margins. And by the time that they had found another lesion, a third lesion, and there was really very little left of my breast, they still said, it's your choice.
Yeah.
Because we can take that lesion off and you can have radiotherapy and the outcomes will be very similar. But you don't have a lot of breast left.
Yeah.
And that was the point in which I said, okay, mastectomy is the right choice for me. It was about the same time as I also decided that I could do advocacy. But speaking of that moment, which
Yes.
was really key, so you have to imagine sort of a person, me, who was depressed, refusing a lot of treatment, not going along with a lot of it, absolutely refusing chemotherapy, and thinking that even though the recommendations were there, I just couldn't do it. And there's this one day, and I describe it in the book, where I go out for a walk, and I start the walk sure that I'm not going to go through treatment. And as I'm walking along the street in Cuernavaca, where I was diagnosed, I think of a woman, same age as me, 2 kids, and she's in another hospital, the public hospital, not the private hospital. And she doesn't have the choices I have.
Right.
Because she can't get the care, either because she can't afford it or because there's no one to take care of those 2 little kids. And suddenly it occurred to me that I was incredibly lucky and blessed. I had Julio there by my side. He was not, always supportive, doing everything to accept me as a woman, me as a mother, me as his wife, me as a decision maker, and would be there to help with our daughters going through this. And I had full access to care.
Yeah.
And there I was saying, no, but I don't want this. I can't do it. And suddenly I thought to myself, I have something I could do. I have a voice. I'm going through this for a reason. And I can use this to try to help all of these other women who don't have the same access I did. And right around that same time, the new national health insurance that Julio had put in place, the Seguro Popular, was covering breast cancer treatment for all women in Mexico. So there was a huge message to give that if you will just be screened and if you will just accept a diagnosis, you will not have to pay for your treatment. You will not be impoverished. We can help you to survive, especially if you're diagnosed early. So I picked up that message, went on with the mastectomy, and had an amazing team of surgeons. But I got to say, I was full on rejecting the chemotherapy for a good couple of months. It was a very personal reason. My father was a concentration camp survivor. Yeah. And it wasn't actually the chemotherapy. It was the idea of looking myself in the mirror and seeing the vision of someone who was in the concentration camps. And the fear for me was overwhelming.
Yeah.
And nothing was getting me through it until I thought to myself of my 2 kids and the little one in particular, who is adopted. We talk about it in the book. And the thought that she couldn't possibly lose 2 moms. And if she was going to, then she had to at least think that I had fought. Both of them need to think that I had fought to give it a shot, to be there for them. And I knew I needed the chemotherapy. And that's what got me in that first round, but which I did at the Seattle Cancer Care Alliance with Julie Graylow and her amazing team. But, after that first round, which was shocking, and all the things that happened to your body going forward from there, it got comfortable is not the right word, but I was really at peace with it. The day my hair fell out, and I write about it, I didn't think I could go out in public. But I realized if I didn't, I would never go. Right? Wrapped my head and went out to a big event and realized that, again, I had this voice, I had this opportunity. And I was very lucky to have all the support in the world that most women don't have. The women I work with, I don't know how they do it, but they have chemo early in the morning, get on a bus, go back to work. all over cities, all over the world. They don't have access to antiemetics. They don't have access to anything that would help them to manage the symptoms, and yet they go on with their lives because it's a chance of surviving. So that's what brought me forward. And there's, whole long 15 years or so of getting towards a point where I had the second mastectomy, lots of surgeries. I went septic in my last dose of chemotherapy, which they say only happens to the wife of a physician. So,
of course.
Right, exactly.
Yes. It's an incredible journey, and the revelation that you're mentioning on that walk really struck me because I think especially providers, oncologists might say, look, you have all these options. How could you not do chemotherapy, or how could you not take advantage of this treatment? And I just felt like you were really reminding everyone that, and sharing today with us as well, that these thoughts, these fears are so personal, and especially the legacy, of your father, and thinking about this horrendous, time in a concentration camp, and, looking in the mirror, that all that is part of being a human being. And then when you get a very, very serious diagnosis like this, it's not just cut and dry, oh, I'm just going to do this medicine, I'm going to have this surgery. And you mentioned something I think is incredibly important, which is choice. And we've talked even on this podcast with other experts as well about shared decision making, and making these decisions together. I love hearing that you weren't just making one choice or one decision, but it's been part of this 15 years you were grappling with these choices and decisions.
Right. And in a lot of the work we do on health systems now more generally, we talk about patient co-creation.
Yes.
We have to understand, and in fact, a lot of the work we're doing now, we have a commission with The Lancet, the medical journal The Lancet, on cancer and health systems, and we're looking at the journeys that women face from prevention through to palliation with a diagnosis like breast cancer. And when you talk to women about their journey and you look at all the different places where they face barriers, you have a really good understanding of what to do in terms of policy that you don't get when you look at the data, and you don't get when you look at the legislation. You don't get it unless you actually speak to the women about literally how they're walking through the health system.
And that's data, speaking to women.
That's speaking to women.
Right.
And Cleo and I talk a lot about how, it's one thing to learn about a health system, and he led a health system, but living it is a whole different story. When you get into that hospital bed and you have to live through, even with health insurance, all of those decisions, you finally understand what it really means to make choices, and make choices about, daily life, choices about your children. But I really wanted to go back to something about the idea of looking in the mirror.
Yes.
Right. So, I remember one of probably was the first big interview I did, and I must have had the first mastectomy. It was fresh, 2 weeks prior. And I'm in front of a microphone like this, it's hanging down. And he said to me, so, you just had a mastectomy. What do you see when you look at yourself in the mirror? And that was exactly like your eyes just went. I was like, what am I seeing? And I thought for a minute, and I realized that even though, this is a fresh mastectomy, a large scar, very prominent, what I saw was a woman that I liked much better in terms of the strength I was seeing in the mirror than the woman before, right? And that's a lot of what imbued me with that strength. And then Julio's sorts of messages along the way, which I know most women don't have, with him saying, to our children and to me, you are beautiful like this. Because our image of ourselves is what is beautiful. I know so many women tell me, no, I don't want to know because my husband will leave me, because I'm going to be ugly if I have a mastectomy, because I need my breasts. That isn't what makes you beautiful. And there's a story in the book where most days I was in pretty good shape, right? But this one day I was feeling pretty rotten, and it took me a lot to get up and walk over to the lunch table. And Cleo was sitting with the two kids, 3 and 11. And by that point I was bald, mastectomized on one side, bloated from the chemotherapy, wearing A-line dresses. And I'm walking over to the table, and he says to the girls, "Isn't your mother beautiful?" I'm like, "Your father's gone crazy, you know what?" But I looked at their faces, and they were like, wow, she really is, and he really thinks this. that kind of a message to our daughters went well beyond the breast cancer. And that's a lot of what I think we can do in advocacy with a disease like this. Yes, we're speaking about breast cancer, but really what we're speaking about is women's rights.
Yeah, and womanhood,
And womanhood. And what is beautiful about us, which is so much more than our breasts.
Right.
And that message has to reverberate throughout our lives.
Right. So loudly.
So loudly, because the real cancer is that societal cancer of machismo, which is the word we use in Spanish, but I can give you in any language in every country. Right.
Yes.
That's the cancer that blocks women from getting care and from believing in ourselves and all
blocks
we can
men.
Be. Yeah.
Yeah. Tell me more. I have to say, I think, and this is my own limitations, maybe in my clinical background, it was really eye-opening for me to hear about the machismo, but also that there was also this fear. I think I've been coming at it from a very clinical perspective, but the fear of being abandoned, of that a lot of women experience. I want to talk about it later with you as well, but, in your book, there's these beautiful letters that I know that your husband gave you permission to publish, where it sounds like you had, luckily, my goodness, such a different experience, right? And for him, not just to write you personally and privately, but then publicly, right? And also in front of your daughters, especially, to promote this other more expansive, right? Definition of beauty, a lot based on experience, right? But how can we combat that? I have to say, I was really horrified to think that on top of dealing with a serious diagnosis, that was going to inform how people felt about their treatment and their daily fears.
Yeah. No, it's huge. So just going back to the husband.
Yes.
Since, this is UCLA Health as well. The husband happens to be the chancellor.
He does.
Of UCLA.
Husband first. Of Dr. Knaul.
Father first. Husband first.
Yeah,
Thank
father
you.
First.
And yeah, he was amazing. We would do talks together, and there would be sort of several hundred women there, and I could tell my story. But the minute he stood up and said a woman is more than their breasts, they would go wild. Like, this is amazing.
Yes.
That this is being said to us, and I think it took us a while to realize just how important that was. Now, for me personally, he was there for every chemo session, and he wrote those amazing love letters while I was in the chemo. And I think I probably nearly broke his heart when I waited and couldn't get into that chemo room. But he supported me at every step of the way through it.
That's incredible.
He was, and he is. And so that's a huge part of it. But, let's speak for a minute about what I think can only be called violence against women, domestic violence against women. And we're doing more and more research on this. I'm helping some collaborative work with an amazing physician here at UCLA Health with Patty Gantz and at our Johnson Comprehensive Cancer Center. So the way I understood it initially was when I realized how many women, not only poor women, but women with whom I was doing advocacy, wealthy women at the top of the social sectors in Mexico would say, my husband left me because they couldn't deal with the diagnosis. And it's not a secret until you start to realize that more and more women have experienced this. And they're afraid of abandonment. They're afraid of being left with children that they can't take care of in the face of a diagnosis that means that they can't often work as hard as they did before. If they were working, they can't pay the medical bills as well as taking care of their kids. And the husband, father of their children, has walked out because of the breast cancer. So that kind of abandonment is a kind of violence that layers onto the trauma of having a diagnosis like this, right? But I think there are a couple of ways to look at this. One is, not all men are going to do this necessarily if we could provide them with some support. So no excuse for the behavior, but I also believe that there is psychosocial support that we can provide to men, to couples, to be able to get through this kind of a diagnosis successfully. It's not easy to watch your partner wake up from mastectomy.
Right. It's also happening to them
It's happening to them in a different way and helping them to be able to cope with it effectively and be supportive. But that kind of couple therapy is really lacking. We just don't do it.
Right.
But then, so I think that's one piece that we could do a lot more work.
Can I ask you a quick question about that? I mean,
Even a long question.
I love picturing your husband and you both speaking to these roomfuls of women. Were there men in the room too? I mean,
there were some.
I just feel like there's that. Because they need to hear that. It's the role modeling, but because you listen to stories, right? I mean, I'm hearing your story. I read your book. I mean, that's going to stay with me, right? But men might be told something, right, or partners, right? But it's incredibly powerful to hear, you and your husband speak together.
I'll never forget the first time that we did this. There was a woman who had just been diagnosed. And she came up and in her best Spanish used a really horrific word, the equivalent of, I will be ugly without breasts. And standing next to her was her partner, who wasn't saying it. She was saying it. Right? And she didn't realize I was mastectomized. And I said, am I ugly? She said, no. I said, well, I only have one breast. And he's still with me. So you are not going to be ugly. But her own image of herself was of that she would be ugly and worthless without her breasts.
And I mean, that part too. I mean, I think partners, men, we, of course, but I want to decenter the men too for a minute and say yes, it's your personal interpretation of your beauty. And so much of that is just internalized, right? Talk about internalized machismo. Yeah.
This is why I also said you don't have a mastectomy for cosmetic reasons.
Exactly. Oh my gosh, exactly.
So it's for a different reason. But so going back to the men. So first, I think there's a lot we could do to prevent some of that, if not abandonment, to improve the way that your partner can support you. Whoever your partner is, by the way, male, female, or other gender. Right. But the other thing that we're beginning to do a lot more work on is, and I have another Lancet commission on this, the level of violence against women and children is horrendous. We are speaking about 1 in 3 women globally, everywhere in the world, and at least 1 in 5 children, girls and boys. And what we can reasonably hypothesize is that kind of physical and emotional and mental trauma makes you much more susceptible to different diseases. It's been hard to prove, but I don't think it's without correlation that the trauma can affect the biology and the cellular level and make you much more likely to get many things. So that's one. But the other is that the whole survivorship part of a cancer journey, breast or otherwise, is tremendously affected when you have suffered violence or when you suffer violence like abandonment during that process, right? The survivorship journey is about recovering your own sense of self and beauty in yourself. And if you've suffered that, it's much more difficult. The other place where I think there's a really concerning overlap is this reason why women will tell me, I don't want a mammogram because I don't want to know I have the disease because I will be abandoned. Right? So that whole problem with later detection, with women not going forward to be checked, is because, in large part, of the violence and trauma they've experienced and the way we've been brought up to think of what we are and what makes us worthwhile as women and as human beings. If we can get rid of that machismo, if we can get rid of that violence, we will have been getting rid of a huge risk factor for at least mortality around breast cancer and many other diseases. That's where I begin to talk about real prevention.
Right, exactly, because there's the fear when you have a diagnosis, but then there's the fear of even finding out, if even getting detected.
Right, exactly. And what do you want to tell me? I want to tell you that you should be afraid of not knowing.
Yes.
You shouldn't be afraid of knowing, because with access to treatment, survival rates are 98% at 5 years in many parts of the world. So you want to find out as early as possible that you have a disease, as long as you can get access to treatment.
And have these conversations, because I think it's very, very instructive to hear that you, even with great access to care, right? Your husband was the Minister of Health, that you still said, but this is my choice and my decision, and you had to think about it.
Oh, I had to think
and that
about
takes
it a lot.
time, right? I think that's an incredibly
it takes time, and it takes a very honest conversation.
Very honest conversation, and the grace to give yourself and everyone around you that you're thinking about something.
Yeah. And I think that idea of conversation is really important too. So it must have been like the third time I was trying to get clean margins, and I was set. And it's the night before, and it suddenly occurred to me, and I said, "Will I have any feeling left?" Like, no. You know, it hadn't even occurred to me.
Feeling in the breast or in the nipples?
In the breast.
Yeah.
Anywhere in the breast.
Yes,
exactly.
Yeah.
So it's like, of course, they assumed I knew, you won't. Now, that isn't always the case. I think surgeries are newer. Things can be, things are different now. There is a way to do nipple-sparing surgeries for some women. If they're caught early enough, there are options. But in my case, 18 years ago, that was not the option. But in the minute that I realized, wait, I will have no feeling, I said, I'm not ready for a mastectomy yet. And like, you got to have this tomorrow morning. And I said, I can't have this tomorrow morning. Because no one had talked to me about all of the different feelings and issues I would go through. And you do, with the survivorship, with the care, with the treatment. There are all sorts of things that you go through. And I think the more we can prepare women for that, the better off they are. Survivorship is all about lots of things happen to your body. Some of them are going to get better and some of them aren't. And so it's better, I believe, that we know about it and we can work with it than not.
I mean, I couldn't agree more. I think, you talk about the word survivorship, and I think you highlight that term a lot. And something we like to talk about a lot on this podcast is language, and the impact that the words that we use, especially in medicine, just have such an impact about how we ourselves are seen as patients, how other people see us, how we talk about things, and in society. I'd love to just take a moment to talk about what that word means to you, and maybe it isn't easy to define, like you're saying. I mean, it's spanning years, moments, tons of different feelings. But I love hearing that you're working with Dr. Patty Gans. I've known her since I was a little girl. I went to school with one of her sons in elementary school. But I just
Patty's been super.
Isn't she super? But even the words kind of survivorship. Tell me a little bit what that means.
So the word survivor is used a lot, particularly with breast cancer. So first, I use the word survivor much more to think about the concentration camps and domestic violence and violence against children. That's where I use the word survivor more. So I had tended to reject the survivor word for that reason. But the second reason is I would be, giving these talks, and you learn as you go along as an advocate. And a friend in the room who had stage 4 breast cancer came down and said, I'm not in your chart. I'm not one of those women who is likely to survive this. And so I'm not a survivor. And then they said, well, everybody's a survivor as soon as you're diagnosed. But all of those women all of those people feel left out of the room. They're in a different room. And I realized, sometimes I'm uncomfortable being alongside my friend, my colleague, the other woman that I'm trying to work with who I know won't survive. Right? That's scary for us. That's the second reason. We have to be inclusive.
Yes.
We don't know, and I do a lot of work on palliative care and end of life. We don't know when it crosses over from survivor into palliative care. We really don't know, and it can go back and
to
forth.
End of life, right? Even that's different, yes.
And you may die of something else in the end. Anything can happen. So I really started thinking about a journey. And for me, the word survivorship talks about a journey. And it's a long journey over time. It's a journey when you can be quite ill at some points and not at others, where you learn to get over the way that your diagnosis and your treatment has limited your life and find other ways to live your life. But it really is, the word journey is the right word. And so I never have liked the idea that either you're a survivor or you're not. It's never convinced me to tell a woman who has stage 4, who's got metastatic disease, oh, you're a survivor.
Right.
And I guess the other part of it is, when we go to the walks and we're dressed in pink and we're, it's not all rah-rah. No. This is why I think we have to allow women to talk about it as it is.
Right.
The first time I used the word amputation for a mastectomy with a physician. They're like, oh no, we don't use that word. And I said, no, wait a minute. You're talking to me about removing a part of my body that is external. Like, what's the difference between my arm and my breast? Mm-hmm. And the physician said, well, women wouldn't accept it if I used that word. And I said, yeah, but it is an amputation. You have phantom breast. Mm-hmm. You feel that you've lost something. You need to talk about it. It's a journey.
And it's your word. It's your word. And if it describes your experience, it's meaningful.
I'm sure. I bet it describes the feeling that women have often, but we don't get to talk about it that way, because even when you're in that like advocacy space, you're supposed to be positive and glad we're alive, and what more could we want? You're allowed to want other things.
Yeah.
You're allowed to mourn what you lost, and you're allowed to talk about it, and you're allowed to figure out the ways in which all the systems around you can help you to do better with that.
I mean, I think it's very hard to exactly define advocacy, as you and I were, briefly talking, but it seems to me that talking honestly, right, is probably the most meaningful, right? And just most authentically representing, right, what people are going through or what they are fearing of going through. I mean, that's really representing, right? Yep. And supporting other people.
And I think there's also a piece of that has to do with discrimination against women and womanhood as well, because we aren't supposed to talk about certain things because it doesn't matter to us. Prostate cancer and impotence is something that, of course, there would be support for men, and of course you would want to work on this.
And tons of research dollars. Yes.
Tons. How much for women? Around what it means to be forced into have your menopause induced, 10, 15 years beforehand. Where is the support for us in that? And then where is the support for that woman as part of a couple who also needs counseling and ways to figure out how to manage that? Mm-hmm. So it's all wrapped up in the idea that we shouldn't care about our sexuality, that we've already produced children, so what more should we do? Or we chose not to, so then what are we? It's really wrapped up in that. And so I think
there's more to beauty than the breast.
Much more.
Yes.
And this is where I really strongly believe that the breast cancer movement can do a lot around gender. I still call it discrimination, gender discrimination, and gender equality for women.
Yes.
For all genders, actually. Because we're talking about a health condition, a disease that affects a particular part of our body and our womanhood, and where there's a huge audience out there. Somehow this pink movement was really extremely successful. Mm-hmm. So I think it's time that we stopped only advocating around our breasts, and we're actually advocating for the rights of women and others to health care and to live a full life.
Yes. And advocating for all of, like, to your point, all the support around the diagnosis, right? All the support for longitudinally, right?
Exactly.
For the cancer diagnosis, the treatment, the psychologically, right? I mean, it's not just again, with all due respect, it's great for us to, do the walks and wear the ribbons. And there's a tremendous, tremendous opportunity for the support, the education, especially around identity along the entire spectrum.
Yep. The whole phase of survivorship care, which is still relatively new, when we look across the world at our data, the part that's missing is almost always survivorship and palliative care.
Yes.
Right? But within certain parts of the world, Patty's being a pioneer on this, survivorship care, the U.S., Canada, Europe, so that has really come to the fore because more and more women are surviving.
Yes.
Like, we have really good statistics to share. We've talked about, all of the suffering around breast cancer, but we should show at least a couple of statistics, right?
Of course we will, yes.
So 45% drop in mortality in the last 30 years, right? That's huge.
Right.
It doesn't mean that there aren't still women who are going to pass from this disease, but it has dropped tremendously.
Yeah, it's incredibly hopeful, and a lot is because of early detection, right, and shared decision-making and treatment.
And good treatment, exactly.
Really good treatment.
Access to good treatment. This topic, the access to Herceptin for HER2-positive breast cancer, discovered at UCLA Health, is
Dennis
huge.
Slayman.
Dennis has, turned that kind of breast cancer on its head
Right.
to a disease that you live with or survive rather than one that takes
Right.
your life. But that 45%, that's like when we talk about any success story,
Yes.
that's a huge success story. The one before that was cervical cancer, enormous success story. This means that like fewer and fewer women should die of breast cancer, but more and more women are being diagnosed with breast cancer.
Yes. Yes.
So it's where say, we're victims of our own success, right?
Yes.
So the fact that we survive longer, the fact that we don't die of other diseases mean we're going to get diseases like breast cancer, and that we have so much more we can do to manage that cancer, but that we also have so many more survivors.
Yes.
So that survivorship care is really important to develop and offer to the many, many women who are going to be alive afterwards.
Absolutely. And even the tools of diagnosis, the tools of treatment, they've been transformative, but we also need to also acknowledge the transformation for those who go through this journey.
Yeah, exactly.
I'd love to talk about, you've been talking a lot about advocacy, which is great. And again, difficult to define exactly. I think that you demonstrate advocacy in everything that you do. And I think that's in a much better way, an illustrative, definition. I was telling you a little bit before, but I'm a total Latin nerd from a long time. And, when you break out the word AD and vocare, it means, to move towards calling, right? And so there's lots of definitions. I think in the 1500s, it was like almost had a more legal definition. But, today I think of it just whether it's representation or summoning or calling, I think of so much of the work you do as giving voice to. And it's just so powerful. And I love hearing how you're talking about data. And I wondered if you could talk a little bit about research and data and how you utilize that to, affect and effectuate policy.
So, the NGO that we founded in Mexico is called Tómatelo a pecho, which literally translates, since you're a Latin nerd, to take it to breast.
Yeah.
Right? We use the term take it to heart.
Yeah.
And that lemma had been used a lot around breastfeeding, but had not been used around breast cancer before. So calling it Tómatelo a pecho means, really take it seriously. But, sort of like our signature piece of data or graph is one where we showed how mortality from cervical cancer in Mexico had been really high in the mid-'80s and had dropped from about 16 per 100,000 to below 8.
Wow.
Around the time that I was diagnosed, 2005, 2006, 2007. But then you look at the breast cancer mortality curve, and it's just like an upward trend. And when we started doing this, people said, oh no, poor women die of breast cancer in Mexico, poor women die of cervical cancer, sorry. And so most of the women in Mexico are dying of cervical cancer. And like the aha moment was when we said, no, actually, the majority of deaths are breast, not cervical. We've been really successful on cervical. We have this huge emerging challenge called breast cancer. And when we could say to our clinicians and policymakers, wait, you need to include information on breast as well as cervical cancer in all of the grassroots work that you're doing on health education for women all over the country. And then we were able to show that it was just in like the poorest regions where there were still more women dying of cervical than breast, and say, look, this is unacceptable. But once you're finished dealing with cervical, you're going to be facing this emerging challenge of the non-communicable disease of the breast cancer. So we were able to really show what we call the epidemiologic transition, looking at cervical cancer and breast cancer. But the policy message was there is this huge tsunami coming at women, and you're not aware of it because you have this false idea that most women have cervical cancer and not breast cancer. And you're wrong. Here this is. So that was one of the ways that we used data, and everybody was incredibly surprised to see it. Everybody being the policymakers, even Julio, when I showed him this figure, was shocked.
Right.
It was just nothing we had seen before. And the more I went in front of, we had an anti-poverty program that worked in the poorest parts of Mexico. And they're like, we're not saying anything about breast cancer when we're doing health education because we don't need to. I said, well, look at these figures.
It's
and
interesting,
it's
like this either or, like we only have room for one topic here. Yeah. Right? Speaking of.
Right.
womanhood. Yeah.
You can actually you can even
We can
face
talk
both,
about-
right?
yes, yes.
Right. And this was when the vaccine was in its very early
Yes.
days. So it wasn't about the vaccine. So that was really a very important message. But the other thing that we used, and I still use, is you need success stories, right?
Yeah.
And when we talk about a 45% decline in mortality in the U.S., we're not seeing the same in places like Mexico. We're seeing an increase in mortality still, and it's going to keep going up, even though it's not nearly at the same level that we saw in, say, the U.S. or Canada. So what do I tell people? I say, look, first of all, you have the chance to take advantage and leapfrog through all this and see and use all of the science that's been developed elsewhere. But the other is I'll go back to the cervical cancer story and say, look, that huge drop in cervical cancer mortality wasn't the vaccine. Mm-hmm. It was women agreeing to have an invasive test called a pap smear. Mm-hmm. And, I'm sure that if we were, sitting in a classroom in the mid-'80s, particularly in Mexico, and saying, oh, women are going to go and have a pap smear, be like, yeah, right. Well, they did, because we are actually able to internalize information that we're given, use it, think about how to protect ourselves, and go and have the tests we need to have. Cervical cancer is an incredible success story,
really
even
is.
before the vaccine. And, by the way, also related to one of the other topics I know you talk about on the show, which is HIV/AIDS, use of condoms. It's linked, right? These are really important stories that link together when we think about public health.
I am so interested that you described the pap smear as invasive, that you're acknowledging that, that it's actually a procedure that, is very meaningful and can feel very invasive for women. I just feel like so much is about, just as you're talking, right, is just undermining, right, or minimizing or dismissing. And just by even you saying that word, it just really acknowledges that these things aren't small,
No. But one thing is to accept that it's an invasive test. Another is to make sure that it's done in a way that's done with dignity.
Absolutely.
And that's true of everything to do with our breasts as well.
Yes, absolutely.
And it's typically, I literally hear about like lineups of women with their top off, waiting to be checked. I mean, this is not how you do this.
No.
And a lot of it is not about money. It's not more expensive to do things with dignity. And we just seem to forget the value of like dignity of the poor.
That's right. Of everyone, for sure. Yeah. We did have one of our, maybe it was our second episode of this podcast was with Dr. Maya Zapata, who talks about, your routine pap test, and it is excellent. But so much of what she promotes is, comfort, normalization, and dignity. And I love hearing that. And I hate to think that that's something that we take for granted, here at our health system or in this country, and that's not, afforded to everyone.
But we can advocate for that.
And tell me how. Yeah.
So one thing is helping women to understand that they have a right
Yes.
to ask for better care and to ask for dignity and to say, I am not willing to accept this, right? To insist that you can have someone else in the room with you, your friend, your sister, to stand up for yourself, which is not easy to do in a situation where there is a lot of trauma and violence.
Yes.
So we think about only domestic violence, but there's a huge amount of work that's being done on, should we call it clinical violence? It's the violence that women suffer when they're in childbirth, when they're going through tests, where that lack of dignity really crosses the line.
Yeah, it's incredibly traumatic.
It is incredibly traumatic, and it crosses a line of what is violence.
Well, and then it's then as you suggested too, there's the future trauma when you don't, for example, take care of yourself, right? Or you're not able to go get that screening test, right?
But a horrible catch-22, no?
Yes.
Like a kind of a weird phrase to use, but that's the catch.
Absolutely.
Either you accept the lack of dignity that it means to go through a test like this, or you're accused you didn't take care of yourself. Absolutely wrong. Absolutely wrong. But I really feel that this is changing in so many ways.
Yeah, I love
And again,
hearing that.
where this is where the advocacy
I was going to say, well,
movements
changing
are-
because of a lot of work that you do, honestly.
No, thank you.
No, it's truth.
Thank you.
Yes.
But the advocacy movement on breast cancer has been huge. We don't hear that around cervical. This is something that's
I think
really
that's
interesting.
very true. Yeah.
The advocacy around cervical is to do with the vaccine. Even if you look at sort of the literature, the Latin stuff, right? The literature, women writing about their own experiences, very few women write about cervical cancer. Many more women write about their breast cancer
That's
experience.
very true. Yes. Just anecdotally, I'm just thinking to myself, absolutely.
Yep. And it's not that there's less cervical cancer, at least historically, but you would never write about that part of your body, I guess. And so we don't have that kind of advocacy. And I think it behooves the breast cancer movement to think about that broader advocacy question. All that we can do in some ways. Cervical cancer is an obvious example, but there are many more.
Such a good point, right? Like change from the spotlight to just like a floodlight, right?
Yeah. Exactly. You know, and it's when we think about, we talk a lot about how science was all about male mice until recently, right? And probably why breast cancer needed that advocacy, because this was a disease that largely affected women. Cervical cancer, the same. So who was going to figure that out or invest in that when you didn't even have female mice to get it, right?
Yep.
We've come a long way. It's huge. And it's not that many years since then. It really is a positive.
It hasn't been many years at all.
No, it hasn't. It hasn't.
I'd love to hear, even more, you mentioned your, the nonprofit, the NGO, a lot of work with civil societies, faith-based organizations. And I'd love to hear just some more concrete examples of, some of the work that you've done. It's just, it's incredibly helpful and inspiring, but it's also, I want it to kind of lead to what can I do every day, that's, in my own sphere.
So when we were talking a little while ago about, I said, you don't need a doctor to do a breast clinical exam.
They use the word health promoters, which is, by the way, in the States, I can say I haven't often heard that word.
Oh, interesting. So it's huge in low and middle income countries, right? So one of the things we did with the NGO, and I was really happy able to partner with Nancy Keating, a physician based at Harvard, we trained thousands of health promoters and primary care nurses and physicians.
Yes.
Right? Around breast clinical exam and breast health overall throughout Mexico. And then we proved, scientifically, we reviewed, we analyzed that they were getting information, they were learning, and they were able to retain that information. So we were teaching them about breast health, teaching them about breast cancer, and teaching them about breast clinical exams. And they now, all of those women, most of them are women, most of the promoters are women, most of the nurses and a lot of the doctors are women, can be in their clinics and in their communities much more prepared to be able to deal with this disease, which gets back to what I had said from that, figure where I was trying to tell policymakers, look, we got to do something about breast cancer. They said, okay, well, what? I said, we don't have mammography for everybody, but let's train the armies of health promoters that we have to be able to do something. The one thing, I've always wanted to do this, I've never had the chance to do it. I really think that if we could look at like nail salons, hair salons, this is where women open up. And I just don't think you need a medical degree to be able to downstage a stage 3 breast cancer that looks like an orange. I mean, my daughter, when she was 6, could have done this.
Yes.
Right?
Yeah.
So that's who we were looking at. We were really trying to think about downstaging communities that didn't have access to mammography and to prove that, health promoters could learn this and retain this knowledge. And I think we did. That was a couple of years back. We got to see where we can go with it going forward. But I have a very strong belief that army of people and communities can do a lot.
Oh, I couldn't agree more. I mean, we have community health workers, and we had Nikki Miller and Jasper Kump on this, the show recently. It's an incredible episode. I'll make you listen to it, but just the incredible work, but the partnership with community health workers. Exactly. And again, you've alluded to this too, the meeting, patients before even people are patients, women, where they are, and you mentioned nail salons. There's been studies, even where we've done been able to improve blood pressure in barbershops, for example. We need to get out of the, this ivory tower of a clinic, right? And bring the medicine and bring the health and the education to people.
Well, I want to try one of my crazier ideas that I've never been able to try. So, I believe that we should be doing a lot of this in school-age children, right? So then it occurred to me a while back, but have not been able to do the study, we should teach young men how to explore breasts. Because it's not that uncommon that it's actually a partner who finds the lump. and not the woman herself.
That has happened to a friend of mine. Yeah, absolutely.
So if we coupled that with an idea of, okay, gentlemen, here's how you actually can effectively fondle a breast, right? They'll learn how to do that respectfully and think about all that it means to be a healthy breast.
Yes.
Right? So I actually think we could combine it with all sorts of important health education and message about dignity and womanhood. But at the same time think, well, 5-10 years down the line, they may actually be finding in their partner something.
Right.
That's like my hope, that we could combine breast health with all sorts of other issues that we need to work on.
I love that. I mean, a big part of even why, we're doing this podcast is because we don't think you have to go to medical school to know how your body works and how to keep it healthy. But what we really want to do is say, listen, you can keep yourself, your partner, your friends healthy. Right. You deserve to have this information. Exactly. Right? And I think especially with normalizing, consenting, right? Nonviolence,
exactly.
To your point, I mean, I can't think of anything more important than you're keeping yourself, people you love, your communities healthy. And even in these cases of, these, let's say their partners, it also gives them this permission and this knowledge, like you might also get sick one day. Right. And I think it normalizes vulnerability and illness and, I don't even want to say weakness, because I think that, unfortunately, I think that has such a negative connotation when really there's nothing wrong without having moments of weakness. And I want to bring this back to your book a little bit, because I've never read a book like yours where there's, and I think there's a lesson in itself, this tremendous power in being vulnerable, in being afraid, being frightened, being haunted, by, family legacies. I mean, that in itself is a story, I think, that when shared and humanized, I think makes things like even just being like, getting a mammogram feel much more, in reach, getting genetic testing in reach, going to a health promoter, a physician, a nurse in reach. And I think that's something that I haven't experienced that having been discussed before. I thought that was really just very unique on top of being very beautifully written.
Oh, thank you. It helped me more to write the book, I'm sure, than anyone else.
We happen to have it right here.
Oh, there it is. That's the English version.
Absolutely. Yes.
There you go. Yeah. That is the English version.
Can you tell me a little bit about the cover? I don't know if you mind showing the camera, which is right this way, but I actually thought the cover was very beautiful too.
So that is a painting by Joy Laville, who was born in Britain, but is a Mexican artist. She passed a few years ago. And if you ever come to the residence, which I hope you will, then you'll see this painting. I would love to have you there. So Joy, I had purchased this painting. Julio bought it for me as a gift when I was in the throes of my treatment. And when we were going to write the book and I had met Joy, I went to see her and said, Joy, can I use this as the cover of my book? And Joy allowed me to. And I here it is again.
It's a real gift.
It's that, nothing is even about this woman. And yet it's very, very beautiful. Everything is a little bit
I would say that
offline.
Is what makes her beautiful.
Exactly.
Yes.
So that is the cover of the book. I wrote it first in Spanish, Tomatelo Pecho, and then it was our little one, Mariana, who picked this title, which has worked very well. I think she might just have watched, Beauty and the Beast or something when she came up with it, I have to admit. But when I said, that's it, because there's no translation for Tomatelo Pecho.
No, that's interesting that you're saying too, and also taking it to the breast, take it to heart. I think that in hearing about the incredible advocacy work, and again, even just how you speak, how can we, as individuals, I guess, advocate for ourselves, for our fellow women? And this is a message, again, for men, women, our children. I mean, on an everyday, I guess, basis, like even, at home.
Right. So I really think one point is to this idea of we are beautiful however we are.
It's a constant message.
It's a constant message. And when you think about something as dramatic as a mastectomy, you really have to think about it in other terms. And especially if put aside the issue of reconstruction, not reconstruction, that so many women don't have access to. So I think we have to bring home this message of what is valuable about us and what is beautiful about us. ourselves, within our families, within our communities, that can come out of a disease as difficult and painful as something like breast cancer. And when we think about breast cancer, we don't think about a message like beauty. We think about another kind of a message around pain, around suffering, around death, around fear. But very beautiful things can actually come out of it. And when I give a talk, I often, and more I've been doing something around the idea of an economics of hope. But the last photo that I always use in my talks is a picture of my younger daughter and I in a butterfly farm in Canada. And so the story is this, that as I mentioned, I went septic in my last infusion of chemotherapy. And for those who don't, septicemia can kill you very quickly. You will be able to explain it better than I, but it is an infection of the blood that goes through your body very quickly.
Very dangerous.
Extremely dangerous, shocking to go through. And if you don't have access to surgery and antibiotics very quickly, you will not live. And so that morning, the day after the infusion, when I was rushed to the hospital and I had to say goodbye to Mariana, I thought, I might not see you again. And, cancer for almost everyone is a disease you live over time. You do have a chance to talk, to say goodbye, to speak in most cases. But that day, there was the only time in my treatment I thought, sweetheart, I might really be saying goodbye to you. And the picture, though, is just a week later. I went into surgery. I had my port removed. Usually, if anybody can get a port, get a port. It's a great thing to have a port. It makes it much easier to get chemotherapy, but ports can get infected. So mine had to be removed surgically. But after that surgery, 1 week later, we're in Toronto, and we go to the butterfly farm. And the photograph, which I'm not sure I can find it quickly, but if I can, I will. It's her watching a butterfly land on a turquoise hat that I have on because I'm bald. And bald was never that easy for Mariana to deal with. But that day that all the butterflies came and landed on my head because of the hat, she's just looking at me like, wow, my mother's the best thing in the world. And the miracle there is it's a week after I had septicemia.
Yeah.
Right? So that we can really draw hope in even some of the worst situations and conditions in the world. And when you draw on that hope, you can think of very different ways to solve it. That's a resource that we have if we can find it. You just have to meander through to identify sort of where it is.
We'll find the photo. I've seen the photo. It's just beautiful. And it's so transformative, which is obviously also just really evocative of just the butterflies, as well, and that transformation. But I love what you're saying about hope. And also it's none of these, I feel like emotions that you're describing are static either, and that's kind of part of the journey as well. So even like the fear that you're describing or the hope, and then, there's that roller coaster, right? You go through surgeries, you're feeling better, but then you get a blood infection. What's your, I guess, I know it's a loaded question, but I want to appeal to your wisdom here. What would your advice, be for people and their families, who are kind of going through these, survivorships, which are really journey ships, right?
So let me give that, and then maybe I'll talk about the systemic message there too. And there's a piece of it in the book. So, when you're in the depth of chemotherapy and cancer treatment, other major treatment, you don't feel well most of the time the way we do. I'll explain this. So when there's a moment when you see something beautiful and you feel well, it really strikes you. In other words, when we're healthy, we don't appreciate it the same way. Most of the moments in our day, we feel good, we feel okay, and we go through our day. When most of your moments you don't feel well, and you have one that's special, it really stands out. And I talk about that in the book, moments with my daughters, moments when I looked at a flower and thought, that is just stunningly beautiful flower. The awe, but it's a moment in time.
Yes.
And you don't get that unless you've lost it. And then you get it back. And now, I miss that kind of awe. And I think, I've got to have that awe because I don't have to feel horrible most of the hours in the day to think about the awe of something beautiful in front of me. And so what I try to do also in a lot of the work I do is think, if you're living in a shanty town that is gray and cold and frightening, and there's a lot of illness, you deserve to have flowers. And one of my great mentors, who wrote one of the forwards of the book, Paul Farmer, was always speaking about how to beautify and dignify the places that the poor live. So he would put, koi into hospitals in remote, poor areas of Haiti. You say, why? So because the poor also deserve to have flowers and fish and something beautiful to see. It makes a huge difference in life to mark those moments and celebrate them and internalize them. And I think when we're healthy, we forget that, right? When it's all around us, we forget how important that is. And then translating that just for a minute to sort of some of the work I do systemically as an economist, it's kind of what's always called the dismal science, right? Everything's too expensive, particularly cancer care.
Well, that's why I'm looking forward to the economy of hope.
Yeah. So,
great title.
But if you look over time, prices of some of the most important interventions have dropped significantly. The price of the HPV vaccine. So what I usually try to say to policymakers is, you would do yourself a huge disservice planning as though the price of that vaccine were going to stay high, and then you were going to take 3 doses, because today, 10 years later, it's 1 dose and it's cheap.
Yes.
And it wasn't like that.
No, it wasn't at all.
So that's the economics of hope, planning for a future that's better than today.
I can't wait for the economy of hope. Are you thinking a book, a movement, a series?
So back to the economics of hope. So the saying is, if we had to cut that piece and go back to it.
Yeah.
So the idea for the policymaker is, don't design your health system and your policy as though the prices are really high.
And for today.
Because believe that it's going to come down. That's also going to help it to come down, right? Because if you expand demand, you're going to sort of should produce a drop in price, right? And that's what we're trying to convince the world to do. And the HPV vaccine is not the only example.
Oh, no. We have a lot of examples of that. I mean, I love this. I mean, I think that it's incredibly hopeful.
Yeah, it is incredibly hopeful.
Right. I mean, even things like, modalities for screening for breast cancer.
Exactly.
HPV. So that's wonderful.
The Hep B vaccine.
Yes.
So the economics of hope, we're kind of building into this Lancet Commission that we're doing on cancer and health systems that I'm really hoping will be submitted soon and published next year here from UCLA. But one of the things that we're really speaking a lot about is, we're calling it there an economics of value.
Yes.
That we have underestimated the costs of not acting.
Yes.
And overestimated the cost of acting, right? That's really the idea of the economics of hope. So we have underestimated the benefits, and that's like the more crucial part in a lot of ways. When I analyze and use cost-benefit analysis, what does it mean to work on breast cancer? I think about only reducing the impact of breast cancer and breast cancer mortality. But if I think that that actually had an impact on women's access to healthcare more broadly and issues around equality and empowerment of women, I need to count all of those benefits as well as being a spillover effect of what we've done on breast cancer.
That's right.
And so when the benefits go up, which is the denominator, the cost benefit goes down and things become much more visibly affordable than they were when we do our initial analysis. And I don't think we've ever really thought carefully enough about measuring all of those spillover effects, right? Poverty, inequity, all the things that I believe we should be caring about are also going to improve as a result of one of the things we're doing in healthcare. And in this case, we're talking about breast cancer.
No, it's a brilliant way of framing it, and also the opportunity cost of not doing those things.
Right.
Yeah.
And the opportunity cost is all of the things you lose, not just
so much loss.
Right.
Yes. And so much psychological loss.
So much psychological loss, so much effect on the family, the children who can't go to school the same way, there are all of those. But this like societal spillover is what we never measure.
You've been so gracious with your time today. And we look forward to having you back to talk about palliative care. I mean, really, I could talk to you forever. You've just been really gracing us with your time and expertise. If I could ask you just our from the rooftops question, what gives you hope? I mean, you've talked about the economics of hope. Anything else give you hope?
Many things, actually. give me hope. When I look at the sorts of improvements that we've had in so many aspects of healthcare, if you kind of take a step back and look at what does it mean to have seen child mortality drop as much as it have? What does it mean to have offered ARVs to people with HIV all over the world, and how important that's been? What does it mean to be able to see that? That's huge. But a lot of the hope probably comes, for them, when I work with children with cancer.
Yeah.
When I
Do you mean when they have cancer themselves or their family members? Oh, okay.
Either
yeah,
way.
either one, right?
But
Yes.
often children with cancer and the survivors, that gives me a tremendous amount of hope. The project that I did that I'm most proud of in my whole life, that I hope we can talk about in some other show, is a project called Sigamos Aprendiendo en el Hospital. We put schools into every hospital in Mexico that had children with cancer, transplants, burn victims. And what I learned there is when you tell a child that they can still go to school, they have the hope that they're going to survive. And even if they don't survive, it becomes so important to them to be able to continue. That gave me huge hope, watching those kids and seeing how that program took hold gave me an incredible amount of hope. I still hold on to that. It was in the early 2000s that we did that, and it's still the project about which I'm sort of, most moved and convinced that there are going to be very long-term benefits of a lot of what we do.
That's incredible. And again, it just, you always, I think, remind us, what we can feel grateful about, in, let's say, the States or a country that, and for people who have access, right? Even within a country like ours, right? There's just the disparities of access is a whole other conversation. But I do think that education, and I mean, just sort of as you're telling me about this, I'm thinking of, sure, children with cancer, but children who's might be in a hospital environment because their loved one's in the hospital, but just not only that lack of disruption, but just what a gift education is.
Yep. And the way that we've seen drops, and so we worked with families where the parents would be functionally illiterate. Like, they could not read the script that was being given to them to provide medication to their children. Right. And we also did an educational program for them so that you have your child with cancer, but mom and dad are actually learning to read and write. I mean, what could be better than that? And it is because of the cancer that this happened. But then when you add it to the opportunities that we have today to save children's lives with cancer, that's huge.
It's huge. And just educating ourselves. I mean, you're educating me. That's its own gift. We're hopefully together educating, our listeners, and, just going back even to the simple point of just knowing your own body, educating yourself about your own body and how that makes a very material and meaningful difference in your life and maybe your lifespan and your quality of life, is incredibly powerful. And I know we have to conclude, and I can't thank you enough for sharing all aspects of this journey. Again, and whether, it's the personal to the public, but I'm just so inspired by the work that you do, the person you are. I think bringing that all together is what's so resonant and meaningful. And I just feel like everything that you're doing is just more just promoting, talk about a health promoter, but just a woman promoter, a health promoter, a cancer treatment promoter, giving, especially women, but all people really at this chance to see themselves, to see others and to really heal. I know that we keep talking about how hard it is to define advocacy perfectly, but I actually really think you have given just this incredible living, talk about journey, just this living picture of what advocacy means and how it can take shape, and even how these smallest, it's not even just actions, the smallest words, the smallest gestures, actions, even just listening, really gain momentum and change outcomes, for people and women around the world. I don't know if there's any last words from you, but I'd love to hear them. I just can't thank you enough for being here.
No, I can't thank you for doing a podcast like this. There aren't that many spaces like this. I know we're reaching out mostly to the community, but I just also want to do a shout out to our students. I was, just teaching about palliative care this morning in our research group, and I said, well, what can we do about this? Right? And we are trying to teach our students that through what they're learning, the skills they're getting, they can change the world around them, which is advocacy.
Yes.
And so you have this incredible opportunity to be able to help a very large group of people to have the skills that are going to make our world a better place. And that's a blessing.
Yeah.
So being here at any of our universities is really important. And maybe, that's kind of at the heart of rebuilding the trust in universities that I know we need to do now.
Absolutely. It seems that, and you're exactly emblematic and personifying this, that being an advocate is really being an agent of hope.
Yeah.
Thank you so much for being here.
Yeah,
just incredible. And for our listeners, like I said, our readers, I always think people are reading everything. But until next time, stay curious, stay kind, stay healthy. We'll have evidence-based resources, show notes summary, a picture of you and your daughter and the butterflies in the show notes, an episode description. And we'll see you next time on Medically Speaking. And Dr. Knaul, thanks for being here today.
Thanks for doing Medically Speaking.